for our patient. So my topic is the future of the psychiatrist. I say part two. Some of you will remember that a couple of years ago I talked about this subject, and this is a new iteration, new and refined iteration. So I'll tell you a little bit about why I'm talking about it, and talk about the history of the role of the psychiatrist, and then 6 areas that I think will impact our future role. Digital psychiatry and precision medicine, measurement-based care, AI, psychotherapy, integrated care, and team-based care for the severely mentally ill. And I'll talk a little bit about implications for the field and for the department. So the reason I'm talking about this is that in 2023, the American Psychiatric Association issued a report on the future of psychiatry, focusing on how the organization should position itself to prepare for predicted developments over the next 10 years. And Rebecca Brandel, who's the president of the APA at the time, and Bob Trestman, who you see here, from Virginia Commonwealth, who's the head of the Council on Healthcare Systems and Financing. They really were the leaders in putting this together. And then Bob decided to establish a work group in this council that I'm a part of to talk about implications of the report for the future role of the psychiatrist. And he asked me to be the chair of that group last year. And so we met over the course of a year and put together a paper, which is currently under review. So one piece of context that was an important part of our thinking was this issue that we have a big mental health workforce, about just under 1 million people in the mental health workforce, and psychiatrists are only 5% of that workforce, the majority being social workers, and then smaller groups of psychologists, mental health counselors, addiction counselors, and others. And the thought was, well, what is the psychiatrist best equipped to do in the context of this workforce? And in thinking about what's the psychiatrist equipped to do, I'll briefly reprise the history of the role of psychiatrists. In the 1800s, psychiatrists were referred to as alienists. Were essentially asylum doctors, leading team-based care for the most severely and persistently mentally ill. I was just saying a moment ago to a few people that Henry Hurd, after whom this hall is named, was an asylum superintendent in Michigan before coming to be president of Hopkins Hospital in 1889. In the turn of the 20th century, we had the era of the psychiatrist as psychopathologist. There was this recognition that there were some conditions we could do something about in psychiatry, and so comprehensive assessment of mind, brain, and body in order to decide whether there was something actionable became important. That's what Adolf Meyer was, our first department chair. In the mid-20th century, we had psychiatrists as psychoanalysts. That role came to the fore. There was a focus on exploration and reshaping of psychological processes. And then the current era, beginning roughly 1980, we had psychiatrists as psychopharmacologists become the preeminent role, with prescribing medications to change neurobiology being at the fore. Now, sometimes this role is referred to as prescriber, and I can't stand that term, which is why we're going to put a line through it. But it certainly captures one element that distinguishes psychiatrists from most mental health practitioners. But of course, we employ other treatments like psychotherapy. And of course, that term leaves out the really critical element of the psychiatrist's unique skill set, and that we have the ability to comprehensively formulate the nature of patients' problems and their likely causes and the most effective path for addressing them. And in doing so, lots of people around the country employ a pluralistic framework built on extensive assessment. And here, this graphic represents our perspectives approach, which is a pluralistic framework for the field. The approach instills hope and confidence in the patient regarding the clinician's commitment and concern, and it leads to greater diagnostic clarity and comprehensive care of the disorder and of the person, and a multifaceted treatment plan. So we move to the first of the 6 topics, digital psychiatry. Digital psychiatry has a lot of components. Certainly one important element is the use of phone apps, and one of these is Mind Lamp, which you see here. And phone apps can collect both passive and active data on patients. The passive approach is collecting from sensors even when a patient's not engaging with the app. And that includes GPS to monitor mobility patterns, anonymized call and text logs to inform social engagement, and voice patterns and activity levels reflecting mood. And then you have active collection, which happens only when the app's being used, and that includes things like completing surveys, self-report scales, taking cognitive tests. And often this happens during real-world activity, an activity that might potentially be relevant to the patient's distress. And the term for that is an ecological momentary assessment. There's work going on with all kinds of digital interventions, work looking at whether digital interventions can work to treat or mitigate conditions. One example is suicide risk, and here's a meta-analysis published 2 years ago showing that digital CBT does work to reduce suicidal ideation and behaviors. It showed an overall improvement rate in suicidal ideation of 40% across many studies. Digital data can be used for precision medicine. Precision medicine is the process of trying to stratify disease categories comprised of patients with varied presentations into more homogeneous subtypes, ideally with differential response to treatments. And mobile data and electronic health record data is an important part of the kinds of data that go in to inform precision medicine. Of course, there are many other data types too, data from genomics and metabolomics and brain imaging and other areas. And when you get all that data together to try to define subtypes, you get very big data sets, and you need people with expertise in informatics and biostatistics to generate the data, to interpret it, to effectively guide clinical care. Digital psychiatry has all kinds of promise. There's also potential dangers associated with it. Collection of digital information can be sensitive, especially for psychiatric patients who might have good reason to have increased concerns for the potential for violation of privacy and confidentiality. A paper looking at mental health apps from a couple of years ago found that 41% of the apps did not have a privacy policy to inform users about how and when personal information would be collected or retained or shared. Let me turn to measurement-based care, which is the concept of routinely collecting patient-reported outcomes through the course of treatment. This involves rating scales of various kinds, typically automated rating scales. And this rating scale data gets generated, and the idea is that the provider talks to the patient about the rating scales and talks about what the trend is showing for these scales. And the idea is that action is taken based on what the data is showing in the context of the provider's clinical judgment and in the context of the patient's input. But you know, it's particularly valuable in the setting of busy practices where these data points can sort of trigger thinking that might not otherwise occur. There have been a number of studies that look at the impact of measurement-based care, and a number have shown advantages for it in psychiatric settings. One prominent example is a paper from Gao et al. In the American Journal of Psychiatry a few years back now, which found that treatment of depression guided by systematic measures was associated with a higher rate of response and remission compared to treatment as usual. The National Network of Depression Centers has had this mood outcomes registry, which is focused on, which incorporates this concept. And the numbers generated from scale scores there, they refer to as mental health vital signs. And the scales they use are the PHQ-9 Patient Health Questionnaire, which is the depression rating scale, the GAD-7 Generalized Anxiety Disorder Assessment, and the Columbia Suicide Severity Rating Scale. Peter Zandi and others wrote a paper about their experience, the NNDC's experience with this, and they had a couple interesting conclusions. One was they felt that it was important to find the right balance between a comprehensive data set, asking lots and lots and lots of information on the one hand, versus a practical one on the other. They felt that in order to sustain this kind of practice, it needed to be a small enough number that it was quick and easy for everybody to use. They also talked about the importance of having the importance of the clinician experience being favorable. That is, they felt like this process needed to be integrated into the clinician's workflow by virtue of being integrated into the electronic health record for it to be workable. We turn now to AI. AI, of course, there's an enormous range of things that AI is likely to do for us eventually. One of the early areas where people think we can make some interesting progress would be in the realm of documentation. And certainly documentation is something that lots of people feel they would welcome help with, because it can be burdensome. There was a study in orthopedics that showed that ChatGPT yielded higher quality notes than dictation or typing. Now I'm sure people are wondering, well, is that unique to orthopedics? I don't see that orthopods necessarily put a high premium, as high a premium on quality notes as we do. But across the institution, there is a pilot project going on right now called Virtual AI Scribe, where a couple methods are being used. One is DAX Copilot for Epic, a cloud-based AI system that can capture and synthesize the patient encounter automatically. It involves just having your smartphone sitting between you and the patient, and it listens to the conversation and it generates a note. And Dennis Antoine in our department is one of the people piloting it, and he said it actually works pretty well. So I think that is something that's actually moving forward quickly. In fact, the institution is about to choose, or may have already chosen, between these two different pilot systems they were experimenting with, and implementation, I think, is starting already across the institution. A study that came out recently looked at psychiatrists' attitudes towards AI, and interestingly, more than half of psychiatrists surveyed were already using generative AI to answer clinical questions, with ChatGPT being the most common one. About half said they do think documentation will be made more efficient by AI, and 80% felt clinicians do need more support and training in understanding these tools. A meta-analysis came out last year of 15 randomized controlled trials of chatbots, looking at chatbots used to treat depression and distress. And it was positive. It said that AI-based chatbots do significantly reduce symptoms of depression and distress, and the effects were more pronounced on chatbots that were generative AI-based and integrated with mobile and instant messaging apps. Psychotherapy. This group of ours that came up with these topics initially did not have psychotherapy in the mix, and then somebody said, a fellow from Mass General said, we should really include psychotherapy. My first thought was, wait a second, the future of psychiatry? What's the future? How does that, what's the forward-looking element in psychotherapy? But I wound up realizing it made good sense to include it for a couple reasons. One of which is that I think, regardless of all the exciting developments that happen, psychotherapy will, the core elements of psychotherapy will always have to be part of what any good psychiatrist has in their toolbox. A solid foundation in psychotherapy skills is going to be crucial for any kind of effective care, in part because, as this graphic shows, this was a common features of psychotherapy study by one of the leaders in that area, Bruce Wampold. Empathy having empathy for your patient, being able to establish a therapeutic alliance. Those things are always going to be essential. But good psychotherapy skills will help us to better assess and diagnose and address the complex interplay of factors underlying psychiatric distress. It'll help us be more adept at engaging with and achieving trust with patients with diverse presentations. It'll help us to more effectively supervise relevant psychotherapeutic treatments and more capably integrate them with pharmacotherapy and neuromodulation and lifestyle interventions. It'll probably also help us manage the dynamics of care teams, which is a topic I'll mention in a minute. And in addition, there are a couple distinctly forward-looking aspects of psychotherapy. One is psychedelic-assisted psychotherapy. Psychedelic medicine we don't know yet quite where it's going to land, but it might represent one of the really important areas of coupling of pharmacotherapy and psychotherapy. Psychedelic-assisted psychotherapy is a good fit for the psychiatrist, really, because of our unique training in both psychotherapy and high-level medical monitoring. At least the way we do it at Hopkins, it includes a framework of psychological support built over preparatory sessions and drug administration sessions and visits devoted to integration of the drug experience. And the digital world is certainly intersecting with psychotherapy. John Torres at Beth Israel Deaconess at Harvard has created a digital clinic where patients do virtual psychotherapy, and then a digital navigator checks in with them during the week. They're reminded to use this MindLamp app for self-monitoring and skills practice between sessions, and then the digital navigator reports to the therapist what kind of progress the patient has made, so that when the patient has their next visit, the person doing the psychotherapy has a lot of information about how the past week has gone for them. Let me turn to integrated care. The model for integrated care that I think's gotten the most attention and been most widely studied is the collaborative care model, where a behavioral health specialist is integrated in primary care, works with the patient, is supervised by a psychiatrist. And relatively recently, the payers have begun paying explicitly for the use of this model. And that represents a significant shift towards integrated team-based approaches. A Cochrane review looked at 79 randomized controlled trials of collaborative care for depression and anxiety and showed a clear benefit, both symptomatic and functional outcomes. And integration is happening in a variety of settings, in clinics like women's health clinics, cancer clinics, HIV clinics. And on the inpatient unit, like with proactive consult liaison teams, Yale was one of maybe the first place to do proactive integrated consult liaison. And they showed that it could reduce length of stay and had cost reductions associated with it. Our FIPS teams here have implemented, and Pat Triplett and colleagues have shown in two papers that there's a reduced length of stay in our practice of that here. So increasing integration has been a trend for a while in psychiatry. That is to say, there was a period where an awful lot of psychiatrists practiced in isolation. Only 23% of American psychiatrists are in solo practice these days. Part of that is because there's been consolidation of healthcare systems, acquisition of smaller practices, and some of that is good because the more integration in general in medicine is probably in some ways good for patients. But there's some problems potentially as well. The trend could enhance the negotiating power of larger organizations, possibly affecting the autonomy and the job satisfaction of psychiatrists, and possibly diminishing quality of care. One of the factors in this consolidation has been the increasing presence of private equity in buying up healthcare practices. And that's placed a heightened emphasis on efficiency as a way towards increasing profit, which might lower psychiatrist satisfaction because of increased workloads and increased pressures. And so navigating this terrain is probably going to require a lot of advocacy from psychiatrists to make sure that patients' needs are being tended to and that psychiatrists' needs are adequately addressed. The final area I want to mention is team-based care for the seriously mentally ill. This is really where psychiatry began. Psychiatry started as a field that took care of the seriously mentally ill. And today, only 65% of Americans with serious mental illness receive treatment. There are good models for how to take good comprehensive care of these patients. The coordinated specialty care for first episode psychosis, assertive community treatment for the difficult to engage patients, certified community behavioral health clinics. These are all good models. Their availability varies across the country. And here you see a paper from Stas Spivak in our community psychiatry program showing that assertive community treatment availability varies quite a lot from state to state. Psychiatrists have to play a critical role in supporting the use of these models and in ensuring that people with serious mental illness receive adequate care. What happens often in these teams is that psychiatrists are pressured in the name of getting the most efficiency out of the psychiatrist to function solely as a prescriber. And it's important that psychiatrists resist functioning only in this very narrow role, because we don't think that's the best path to quality. Psychiatrists really need to continue to be trained in comprehensive assessment and treatment approaches, which helps ensure this kind of whole person orientation. We do train broadly across the country. We train in medical, psychological, and sociological approaches to understanding behavior and treating mental conditions. And we really need to resist efforts that are occurring in various places around the country to limit training and focus narrowly on medical models and management. Residents should be trained in leadership and management skills to support our roles in multidisciplinary team leaders and supervisors. And residents should also receive training in mental health services organization and financing and policy. There are 26 public and community psychiatry fellowships around the country, and you could imagine other possibilities: joint residency and MPH, joint residency and public policy degrees. So again, psychiatrists do play a pivotal role in advocating for the needs of the most vulnerable patients. And educators and leaders should encourage engagement with the seriously mentally ill through promoting opportunities for flexible and blended work experiences. Again, I'm thinking about the fact that there are people who prefer solo practice, and one of our group's thoughts has been that, well, maybe those folks should have opportunities to work at least part-time in public mental health or other comparable settings to remain connected to a community of peers who have a shared sense of purpose. Because really those opportunities, they leverage the psychiatrist's broad expertise, and they probably lessen the likelihood of becoming disenchanted and burned out. So what are the implications of all of this? The psychiatrist of the future will increasingly be a mental health team leader in areas like integrated care and care of the seriously mentally ill. Certainly psychiatrists will be, to some extent or other, digital psychiatrists using digital data, measurement-based care, mobile and computer-based treatments, making full use of electronic medical records and AI algorithms. More specifically, to start with digital data and precision medicine, certainly training in this area is going to be essential. And it'll require education both about opportunities but also inherent risks and how to mitigate them. And privacy and security are going to have to be central elements in forming the optimal use of mental health apps. With regard to measurement-based care, we need to embrace measurement-based approaches to psychiatric care. And education will be needed on the strengths and the weaknesses of available scales. With regard to AI, we need curricula to provide critical skills to evaluate AI tools. And we need to teach trainees to vet AI-generated information and not just hand over clinical decision-making to it. There's going to be research needed on reliability for note writing, for billing, for predictive analytics, and a lot of other areas too. With regard to psychotherapy, training will need to continue the kind of training that includes didactics, that includes clinical cases with supervision, and the experience of integration of psychotherapy with digital therapeutics and with pharmacotherapy and with novel medications like psychedelics. With regard to integrated care, more residencies should adopt curriculum in this area. There's actually an American Psychiatric Association sort of sponsored curriculum that a lot of places have adopted. We should support consolidation for improved care coordination, but recognize that if the drive for efficiency can increase burnout and diminish care quality. With regard to team-based care for the seriously mentally ill, again, we need to train broadly in comprehensive assessment and treatment skills. We need to train in leadership skills, and we need education in health services. We also need to advocate for regulations that will facilitate people who are primarily in a private setting working in a public setting as well. So what about for our department in particular? You know, a lot of these things are things that we have always done and continue to do. So we've always focused on the most challenging cases, the psychiatrically complex, the medically complex, the treatment resistant. That's not going to change. We already do ample work with the seriously mentally ill, certainly in our inpatient settings and in our Hopkins and Bayview community psychiatry programs. Much of our work is in teams, certainly the inpatient teams. We have integrated care settings that are team-based in some of our clinics as well. We very much employ a comprehensive pluralistic approach. You know, one thing I think we haven't done a lot of yet, and that is focus on becoming tech savvy. We probably will need to adapt and become more tech savvy. There is a move to hire some faculty in data science and informatics in the department right now. We've talked about putting in a precision medicine T32 training grant to the NIMH. We probably should do more in the way of training in leadership skills and in health services and in policy. We do have a public mental health track in the residency, and that's important and valuable. More explicit team leadership experience and training might be a good idea. We should consider a public psychiatry fellowship. So I want to thank the co-authors from our department on this paper, which is under review. Ann Rubel, Bit Yaden, and Peter Zandi each contributed to this paper. And then we have some terrific co-authors from around the country, including Marquita Wills, who is the new CEO of the American Psychiatric Association. So with that, I'll stop and love to hear questions from you all. Thanks. What do you think? Covered a lot of territory. Graham.
person who she met, and Adam's kindness for her. And I think that is, we have to be wary of imposing too many layers between us and the patient. And so my concern in the digital realm is all the things that might get between us and a direct experience with the patient.
Okay.
It's all good news that you're bringing, but I also think we just have to be mindful of the risk.
Okay, for those who might be watching on our media stream feed, Dr. Redgrave wanted to caution against moving too far in a digital psychiatry direction because he was very struck by our patient's comment in the interview about how important kindness was. I completely agree with you, which is why this was not a talk on the future of psychiatry is digital psychiatry. It was a talk about 6 different arenas, one of which was psychotherapy. And I'll just reiterate the point I made there. I thought it was so important that we include psychotherapy because empathy and therapeutic alliance are such a central element to doing a good job with any patient. And I think you're absolutely right that the kindness of the doctors is sort of an element, to my mind, is a reflection that psychotherapeutic elements must have been present in the interaction with that patient to have generated that kind of good feeling. Dr. Collins, thank you for being with us. Dr. Collins, for those who don't know, is the chair of the mental health department in our School of Public Health.
Thank you for the talk. I just wanted to add something to psychotherapy. For those of you, I used to lead an office at the National Institute of Mental Health, and psychotherapy rose to the top in terms of future interventions for mental health because the more that we learn about circuits being responsible for mental illnesses, the more that psychotherapy becomes an intervention to retrain circuits, right? And so recognizing the importance of psychotherapy as a clinical skill, but also as a potentially, we would like to continue to have people focus on intervention.
Thank you. Again, for those who are listening virtually, Dr. Collins talked about how psychotherapy will continue to be important, and it may be part of what retrains aberrant circuits. And I suppose psychotherapy has the great advantage in an international context of being probably, I imagine, the lowest cost or most easily implemented intervention. No, not necessarily. It's easier to prescribe. Well, that's true. That's a good point. Here, go take this generic medication. Dr. Margolis.
Yes, this is a wonderful list of where things might go in the future. There was something, maybe everyone has their own thing of what's missing, but one of the items on the list I was wondering about is research, psychiatrists as research participants, research leaders. How does that fit in to the future?
Yeah, and I will say in the paper, in the discussion section of the paper, we talk a little bit about the fact that this does leave out that what I think of as an enormous area, which is that even if you take a clinical view, you might argue that the future of new medications, new neuromodulatory approaches might be considered a part of the future. To be honest, I mean, I do think those are important, and it was partly a matter of not trying to, partly because that field is such an enormous one in itself that it felt like it would be too much to include it. Certainly that is an important area, there's no doubt about it. Dr. Sedlak.
Thanks for all that. Do we have a sense as to, over time, computer scientists are obviously going to be thinking about how they can generate revenue from AI and selling it to insurance companies and providers. Since the introduction of electronic medical records, has healthcare dollars towards that enterprise stayed constant, or the percentage evolved over time? And is that a lesson for AI's future?
That's an interesting question. I have absolutely no idea of the answer to it, but it's a very interesting question. Has the amount of dollars gone in electronic medical records increased as a percentage of all healthcare? Does anybody know? I don't know. Okay, we'll have to do some homework on that one. Dr. Nestat.
Are there any concerns about the validity of the screening tools that are being used in these apps, etc., and the implications for psychiatry as a consequence?
Well, yeah, right. So that has been a big question mark. when it comes to apps, a big question mark has been, well, how many of them have actually been systematically studied to demonstrate that they actually work? And I think the answer is there's been some study, but not a whole heck of a lot.
I'm referring more to just the screening and diagnostic instruments and tools that are being used and shortened to make them easy and administer. And concern that maybe they are actually affecting our understanding of psychiatry in general and pushing us in a particular direction of their own making.
Yeah. No, that's a good question. And of course, I guess everybody probably is well aware that all of these commercially developed apps have the huge problem that everything that's commercial in medicine has, and that is that profit incentive is at sort of the top of the list in terms of what motivates people. Maybe that's a little too harsh. The profit motive plays an important role, let's put it that way. And that sometimes means that the product is marketed to do things that it hasn't been proven to be useful for. And that's not exactly what you're getting at. But that's the right, that's Dr. DePaula.
Yeah, I think there should be an explicit role on your list of 6, and maybe should be 7. For I think the most fundamental role we have, and that is evaluating and formulating patients.
Yeah.
Who's going to take the history, who's mentioned these psychopathologists. I think that should be absolutely square.
Yeah. Yeah, and I did try to emphasize that early in the talk, that I think that is a very crucial role for that. It is a very central role for us. Absolutely, Dr. Bray.
So I was really interested to hear your discussion of AI and how you see that as being integrated in the future of psychiatry, and also really interested to hear this conversation about the role of AI in psychotherapy. You know, it strikes me that you know, as I learn more about psychotherapy, it's more than just saying the right words in the right order, right, at the right times. I'm curious what your thoughts are about the role of these AI chatbots as a psychotherapeutic intervention.
Yeah, well, so this meta-analysis of chatbots seemed to say that it helped, but you know, of course, there's. I hope everybody. I think we all know that you know that studies vary in their quality, and the fact that if one study says this works doesn't necessarily mean it works. I guess my own take would be that there's certain kinds of skills, CBT skills of certain types, that probably that probably have some value in a somewhat automated in an automated form of delivery. But I agree with you that sophisticated psychotherapy requires a whole lot more than formulas or protocols. You know, my own quite limited use of ChatGPT suggests that it is getting very, very smart and very nuanced, very fast. And so, again, this is about the future of psychiatry. Do I trust AI to do great psychotherapy today? No, but I could see the possibility that in 5 or 10 years it might. I don't know, other folks may have more sophisticated views. Sam.
Thank you for this talk. I was struck by the statistic of 65% of people with severe mental illness going untreated. And I heard you mention near the end of your talk that you were brainstorming or workshopping ideas that might get psychiatrists more engaged with treating this population, by incentivizing them or positioning for closing this gap. Mind speaking more about that?
Well, you know, one thing we were thinking about in particular was the fact that there's, you know, that right now you're either in the public, you're either a psychiatrist who accepts Medicare and Medicaid, or you're not. And for the large number of there are a lot of very talented psychiatrists out there who opt out of that public funding system. And so one thought was, well, it doesn't necessarily have to be that way, that you're either in or you're out. It might be that we would do more good than harm if we allowed people who are opted out to spend 1 day a week where they're in and can actually be part of the system. Okay, thanks everybody. Oh, Karen, do you have one more question? Thanks. If you want to stay around and listen to Karen Swartz ask a question.